Hi guys, today we're going to be talking about the Nottingham Extended Activities of Daily Living Scale and the Lawton Instrumental Activities of Daily Living Scale. So we are going to start with the Nottingham Extended Activities of Daily Living Scales, abbreviated NEADLs. So we're going to start with a general description. So it is a self-report assessment that looks at mobility, kitchen, domestic, and leisure questions. So clients are asked what they actually do, not what they can do. So it's a record of activity, not capability. For age range, you would typically use it with older adults that are experiencing a decrease in function for a variety of reasons. If you put a number to it, I would say above 18, just because it does ask about IADLs, and you want to make sure that your client developmentally is actually doing those occupations. It was developed originally for the stroke population in the UK. It's now being used with MS, obstructive pulmonary disease, heart failure, and total hip replacement. It takes about 10 minutes to administer. It's a pretty straightforward worksheet. Type of assessment, it is a self-report functional assessment, and according to the ICF, the NEADL measures levels of activity and participation that may relate to quality of life after stroke. For outcome measure, it is considered to be a long-term outcome measure, and in electronic medical records, it is used to assess if a client is achieving a long-term goal of therapy. So generally, you use it multiple times to assess progress, and you don't really use it to write goals. For administration, one source said it can be used as a postal or telephone questionnaire. It could also be used as like an intake form that the client fills out before they even see you, or you can do it more like an interview if you want to gain more information during an occupational profile. Answers should be given by the person who is the subject of the questionnaire whenever possible. If not, it should be a family member or caregiver that is very familiar with their daily activities. For scoring, there's a total of 22 questions and there's 4 responses for each question. So the NEADL was originally a dichotomous scale where you got a 0 or a 1 for each question, 0 meaning you're dependent, 1 meaning you're independent. Some studies are now scoring based on a 4-option response where you either get a 0, 1, 2, or 3 for each question. And an article from 2002, 2008, and 2011 actually used the 4-point scale. So you either get 0 to 22 or 0 to 66 for your total score, and higher scores equal greater independence. So this is the actual assessment. It's pretty straightforward. You can see at the top, it asks the client to record what they've actually done in the last few weeks. I included the PDF for the assessment if anyone's interested in printing it, and I also included a link to some helpful guideline notes. So this is my video demonstration where I do it more like an interview, and I also explain to the score to the client, which you wouldn't necessarily have to do, but. Hi Kathy, my name is Allie. I'm going to be your occupational therapist today. How are you?
I'm hanging in there. Nice to meet you.
Nice to meet you too. So you had a stroke and then you finally got discharged to home. So I'm here today to check in on you and see how you're doing with your daily activities and just making sure you're safe. I actually brought an assessment with me today. So this is called the Nottingham Extended ADL scale. So ADL stands for Activities of Daily Living. So that's anything you do throughout the day. So you can either fill this out independently and I can just help if you need it, or we can go through it question by question. I don't know how you feel about going through the paper alone.
I'm having a lot of trouble with my arms.
Okay.
So I need help with it.
Okay, that's no problem. So we're going to start with the mobility questions. And before we jump in, I just want to emphasize that when you answer each question, I want you to tell me what you've actually done in the past couple of weeks. So we'll jump right in. So the first question is walking around outside. So there's 4 choices: not at all, with help, on your own with difficulty, or on your own.
I don't leave my house. I don't dare. I'm
Okay.
scared. So
Okay.
I've stayed inside the entire time.
Okay. Just a fear of falling right now with the weakness on your one side? Okay. What about climbing stairs? Not at all, with help, on your own with difficulty, or on your own?
Not at all.
Okay. So I noticed you do have stairs in your house. Do you have access to everything on the one floor?
Yes.
Okay. And you also have your husband to help if something's upstairs?
Yeah.
Okay. Getting in and out of the car. Right. So that is actually the end of the assessment. So I do want to go through the score with you. So it's scored out of 66 points and you received a 13 out of 66. So the higher the score, the more independent you are. So we are kind of on the lower end of the scale. I think we really need to work on using both sides of your body in some of your daily activities, and also just bringing some of those meaningful occupations back into your life, like socially participating with friends and some leisure activities. So we're going to work on that in therapy.
That would be great. I need help.
Okay, so that was the video demonstration. So now we're going to move into psychometrics. So there are no norms for self-report assessments, so we'll jump right into reliability. So for stroke patients, the NEADL actually has well-established reliability and validity in patients with stroke according to 4 different studies. I did find an article on multiple sclerosis that had a retest reliability that was satisfactory, and it fell at 0.81 to 0.9. With the MS study, they did say that further items may be necessary to increase the suitability of the needle for MS versus stroke. They said they really needed more extreme items and that they do have difficulties in different areas. I also found a Turkish version that had retest reliability of 0.84 to 0.97. For validity, I just talked about the stroke patients. With the Turkish version, they actually compared it to the modified Barthel index, which I thought was really interesting because I think this is more of like an ADL scale than an IADL scale. They did find the construct validity to be statistically significant, and I included the p-value on there. For the French index, I thought this was a more reasonable comparison because this does actually look at IADLs, and I included it on the slide if anybody wants to review and compare them, but they do hit on pretty much the same categories, and concurrent validity with the needle was good to excellent. Interestingly, I did find information on minimum detectable change and minimal clinically important difference, and I included the definitions in the notes if you guys want to review those. For MDC, according to one research article that scored the needle from 0 to 66 points, a clinician can be 90% confident that a change of 4.9 points on total needle score indicates a true change. And for MCID, if mean change scores are between 2.4 to 6.1 points on the total needle, a clinically important change may have occurred after treatment. So it is interesting that they tried to come up with these values for a self-report assessment because it is so objective. And we're going to talk about these values in the discussion forum and how important you guys think they are. So next we're going to switch to the Lawton Instrumental Activities of Daily Living Scale, abbreviated the Lawton IADL. So just a basic description. So what areas it assesses. So it really looks at tasks needed to live in the community independently. And it was developed by Lawton and Brody in 1969. So I included all of the IADLs that they look at. There's a list there for you guys to read. For age range, I would also say above 18 again, because it is looking at those more complex IADLs and you want to make sure developmentally that your client is actually doing those. Their target population was actually older adults in a community, hospital, rehab, or skilled nursing facility. The length of the assessment is approximately 10 to 15 minutes, so it's a pretty straightforward worksheet that is self-reported. For type of assessment, it is also functional self-reported, and for outcome measure, you're really going to use this as a long-term outcome measure to see if they're achieving their long-term goal of therapy, meaning you would re-administer the scale multiple times. For administration, it can be administered as a written questionnaire where they fill it out alone, or you can do it by interview if you're trying to gain more information from it. For scoring, for each of the 8 tasks, the client can either be scored with a 0 or a 1, meaning the summary score ranges from 0 to 8. Higher scores indicate higher function and more independence. Interestingly, with this one, scoring does take sex into account. So historically, only 5 sections were scored for males, due to a lack of participation in food prep, housekeeping, and laundering. And I think as OTs, this just really reminds us that the scales we use need to be relevant to the occupations the client is actually engaging in. So this is the actual assessment. So you can see the 8 questions there, and you choose 0 or 1 for each, and then you score it at the bottom. I did include the link for the PDF for that one too. And then this is an interview video demonstration again, so we'll play that. Hi Kathy, my name is Allie and I'm going to be your occupational therapist today. How are you?
I'm good. How are you?
I'm good.
Nice to meet you.
Nice to meet you too. So this is your first appointment in outpatient rehab. So today I really want to get to know more about you and also just identify where you might be struggling in your daily activities. So this is a scale I brought with me today. This is the Lawton Instrumental Activities of Daily Living Scale. So this is really going to go through those harder daily activities you have to do to be independent in the community. So this is a scale that you can either fill out independently and I can sit here and help, or we can go through it together question by question.
I would rather do it together.
Okay, so we're going to jump right into the first question, and if you have any questions throughout it, just stop me.
Okay.
So the first question is about your ability to use the telephone. So I'm going to read all four options. One is you can operate the telephone on your own, so you can look up and dial numbers. 2 is you dial a few well-known numbers. 3 is you answer the telephone, but you don't dial. And 4 is you don't use the telephone at all.
No problems with the phone. I would say 1.
Okay, good. So next is shopping. So 1 is you take care of all your shopping needs independently. 2 is you shop independently for small purchases. 3 is you need to be accompanied on any shopping trip. And 4 is you are completely unable to shop.
I would say 2 because I can't do the heavy lifting anymore and I don't have anybody to help me. So I'm married, but I go by myself.
Okay, that's good to know. So, okay, Kathy, so that is actually the end of the assessment. So what I've done is I've added up your score so you can get a score from 0 to 8. And right now your score is a 6. So the higher the number is really the more independent you are. So 6 is towards the upper end of the scale. So what this is really showing me is we need to work on some energy conservation stuff so that you're not losing your energy when you're cleaning your house. And then maybe working on like the heavy items when you shop and how we can adapt to that. So that's what we're going to work on in therapy. And at the end of therapy, we'll probably take this back out again and reassess.
Okay, wonderful.
Okay, so that was the video demonstration. So we'll jump right into psychometrics. So for reliability, one source said little is known on the reliability. I did find research done by Lawton and Brody, and they found inter-rater reliability to be 0.85. I also found an older study on self-report ADL scales that had inter-observer reliability of 0.99 and test-retest reliability of 0.93. For validity, I had one really older version that did compare the Lawton to the mini mental status examination, and I thought that was an interesting comparison. They were mainly thinking that IDLs require cognition. What they found was that other factors in addition to mental status affects functional ability, so the construct validity was low. I did find a Spanish version though, and I included this because they compared it to the WOMAC, the Quick Dash, and the Barthel Index, which we're all familiar with. And for convergent validity, they found a strong correlation between instruments that measure activities of daily living and functional capacity. I also found information on MDC and MCID. For MDC, it was much greater than a point. And for the MCID to exceed the MDC, at least 482 patients were needed. For MCID, it was between 0.31 and 0.77 and 0.31 and 0.54, depending on the statistical analysis that they were using. I just wanted to mention this from one of my articles. So they said that patient self-report rating was higher than the rating by direct observation of performance. So this illustrates the importance of directly observing an individual's actual performance to obtain an understanding of their skill. So observation is so important, but also it's important to keep in mind that these self-report assessments can tell us a lot about a client psychosocially. So these are my discussion forum questions. Which method of scoring do you prefer for the needles and why? Do you think normative information and MDC and MCID have a place in self-report assessments? And finally, how can observation help an occupational therapist to gain more insight on self-report scores? So for example, think about behaviors displayed by the client during the needles video. And these are my references.